The topic we're going to discuss today is about the urinary tract infections, and more specifically, we'll be talking about their surgical approach or a logical approach secondarily to the UTIs. There are many causes for the urinary tract infections, and there can be complicated UTIs and there can be uncomplicated UTIs. Now, when we talk about the uncomplicated UTIs, they're mostly treated with empirical antibiotics and good hydration and fluid therapy and all those painkillers and everything, which is actually the conservative treatment. Now, when you talk about the complicated urinary tract infections, they're actually complicated by the pyelonephritis, or they may be complicated by the abscess formation, which can be a cortical abscess, which can be a corticomedullary abscess, or which can be a perinephric abscess. So depending upon the complications, maybe end up with a scarring of the renal parenchyma. So what happens is, like, obviously you have to deal with the surgical part, and then you have to go for a proper drainage, or you have to do the nephrectomy if it is accompanied by urinary tract infections leading to renal scarring. Now, before going into the details of the urinary tract infections, their etiology, their signs and symptoms, we're going to go back and look at the anatomy of the urinary tract. Now, we have the upper urinary tract and we have the lower urinary tract. So when you talk about the upper urinary tract, that means we have the kidneys, the renal pelvis, and the hilum of the kidneys, and then you have the ureters. So right here, there is a diagram coming on your screen. There's actually the kidneys, and if we talk about the anatomical structures, so we know that we have a perinephric fat and a paranephric fat, and then you have a proper renal capsule, which is encircling the whole of the kidney, kind of a protective capsule for the kidney. So just on the top of the kidney, you have the adrenal glands, which are responsible for the endocrine functions. I'm not going to go into the details of the functions of the adrenal gland. But coming back to the kidney, you can see here, this is the upper pole of the kidney. Then you have the middle pole, and then you have the lower pole. And two important parts within the renal parenchyma is like the renal cortex and a renal medulla. So you can see the outer part, this is all the renal cortex, and the inner parts with the renal pyramid is actually the renal medulla. So you have the pyramids with the apex and the base. So apex is actually facing towards the renal papillae, and these papillae join together to form the renal pelvis, and then this renal pelvis get entry into the ureter on the both sides. And then these ureters, they have some important constrictions on their way. I'm not going to go into the details where these constrictions lie, but actually they are important when you're discussing about the stones, or when you're talking about the hydronephrosis. So they actually come all the way down, and then these ureters bilaterally, they take the oblique part and they enter into the trigone of the bladder, which is actually the posterior surface of the bladder, combining with the detrosal muscle, and they gain entry, and then the trigone is then actually gaining entry into the urethra, and that's how makes up the lower part of the urinary tract. Now, when you talk about the blood supply, and when you talk about the venous drainage, so we know that we got the renal veins, and when you talk about the order, so it's actually vein, which is the vein artery, which is gaining entry into the renal hilum, and so you can see the renal artery, which is directly coming from the abdominal aorta, and the renal vein, which is emptying or draining into the inferior vena cava. So we have the adrenal veins, and we have the gonadal veins as well, or you can say the testicular, when you talk about specifically in the males. So left renal vein is a little bit longer as compared to the right renal vein. Right is shorter, left is longer. And reason for this is that the gonadal veins, left gonadal and left adrenal veins, they drain into the left renal vein, and then the left renal vein drains into the inferior vena cava. But that's opposite, or that's kind of a different as compared to the right side. So on the right side, you have the right adrenal or right gonadal vessels. So they directly drain into the IVC instead of right renal vein. Right? So that's the main difference between the right drainage of the right side and the drainage of the left side. So you can see here, this is actually the part, these are the, if you could see the number 7, this is actually the adrenal gland. Then you have the renal artery, you have at 8, and at 8 this is renal artery, this is the renal vein directly getting into the IVC. Then you have the renal artery, which is coming from the abdominal aorta. Then you have the whole of the kidney. This is the parenchyma, specifically the middle lobe of the kidney. Then you have at number 3, you have this ureter, which is actually the renal pelvis. Then you have 4th is again the ureter, and 5 is the trigone part. 6 is the urethra, and then 9 is the inferior vena cava. 10 is abdominal aorta, and you can see the bifurcation of the abdominal aorta into common iliacs, right and the left common iliacs. Then at 11, this is actually the IVC, which is bifurcating, and this is the right common iliac and the left common iliac. Then you have the other structures. This is the liver, and these are the bony marcations, and you can see the part of the at number 13, it's actually the sigmoid colon, the descending and the sigmoid colon getting entry into the rectum. So this is about the anatomy of the urinary tract. Remember, we divided into lower urinary tract and upper urinary tract. The upper will be composed of the kidneys along with the poles, upper, middle, and the lower, the renal pelvis, and the renal calyces. And then you have a ductal system, which starts from the ureter, and it goes down all the way to the trigone of the bladder, and then you have the urethra, which is actually entering into the urethral meatus, and there are different parts of the urethra. I'm not going to go into the details of that. Now, because urinary tract infections, they're more common in the females as compared to the males. The reason being is the length of the urethra. So if you talk about the mode of the infections, it can be hematogenous spread, or it can be because of the ascending infections. So what actually, when I'm talking about hematogenous spread, what does that mean? So that means that there is already some focus of infection, maybe in the throat and tonsils, or maybe a kind of a respiratory infection, or maybe a skin infection in the form of a boil or carbuncle that gains entry into the blood, and by the help of the blood, it comes all the way to the kidneys. So most of the time, these cortical abscesses and corticomedullary abscesses, they're actually they are blood-borne, or they're hematogenous, right? And when you talk about ascending infections, so the organism mostly responsible are the gram-negative bacilli, and obviously the E. coli. And these, they ascend from, because they're the lower part of the urinary tract is, communicating with the exterior, and its E. coli is a normal pathogen related to the gut, and it can some kind of the ascending infections, they can travel all the way from the bladder to the ureters and to the kidneys. So they can actually lead to the pyelonephritis. So remember initially that there can be a complicated UTI and there can be uncomplicated UTI, as I have already discussed before. So the uncomplicated UTIs are those in which the patient presents to you with the urinary tract infections. You treat your patient with the fluids, or you treat your patient with the antibiotic therapy, and the infection is resolved. But in case of the complicated urinary tract infections, they are accompanied by renal scarring, they're accompanied by the abscess formations, and they're accompanied by the pyelonephritis. And because of the continuous fibrosis and a renal scarring that will end up in a renal parenchymal damage, and that will lead to the functional disability of the kidney, and the functional nature of the disease would be more pronounced. And if you talk about the glomerular filtration rate, which is actually the when you go for a serum urea and the creatinine levels, creatinine is actually showing you the functional capability of the kidney. So EGFR would be low and the creatinine levels would be high. So that will lead to the reflux, you can say kind of a nephropathy, or because secondary to the infections, they develop a full-blown nephropathy. So more common in the females because their urethra is short, and because of the small length of the urethra, there's a more chance of infections, especially the sending infections, traveling from down to the above and complicating the urinary tract infections. Now, there's another group in the children which has a different cause most of the time, which is a vesico-ureteric reflux, and we will be discussing this in detail in today's lecture. But almost, if you talk about the population group, especially the children, and when you talk about their percentage in boys and girls, so it's actually more common in, it's almost the percentage is 3 to 5% in the girls and 1 to 2% in the boys. But again, the percentage and the age group is that matters a lot. If it's more, if the age of the child is less than 3 months, so it has more preponderance towards the boys, and greater than 1 year has got more predisposition towards the girls. So that's a kind of a statistics. But actually, when you talk about adults, the cause mostly, it can be because of obstruction, or it can be because of ascending infections, right? So this is a theory which is vice versa. Some people say that there is kind of ascending infections, and because of the infections, the function of the kidney is being compromised. So there is urinary stasis, and because of the urinary stasis, there is more of the bacterial growth, and then obviously the function is being compromised, and the urine then crystallizes and leads to the formation of these stones. The other theory says that it's vice versa, because there is already obstruction, there is a stone anywhere in the ureter or in the upper middle or the lower pole of the kidney, and because of that there is a stasis, and because of stasis there's a backflow of the urine, and bacterial growth is superimposed because of the urinary stasis. So it's either way. Both of the theories are accepted widely. Some people believe that there is a urinary tract infection, and then because of the urinary tract infection, the kidney function is being compromised, and there is crystallization of the urine leading to the formation of the stones, and then there is more of the bacterial overgrowth, and obviously sending infections travels. Then the other theory says that there is infection, there is a stone, there is obstruction, and because secondarily to the stone, there is urinary stasis, and there is bacterial overgrowth, and then that's the cycle that continues.